wanted to emphasize that these will give a rough idea, and every candidate has to work on their own weak areas to get maximum out of it from tomorrow. And also, as surgeons, daily we'll see a lot of surprises intraoperatively and postoperatively. Exam also, please keep in mind, lot of surprises will be there either in the case or in the post-case session. So this is the rough skeleton wherein examiners will be expected to tell you in the same lines, like a definition, indication or indications, pre-operative preparation, consent, special consent apart from regular informed consent, type of anesthesia, position and all these things. But as a candidate, what you try to do is you try to start from definition and you'll try to go to complications so that your job will be done. But as an examiner tries to see your concept whether they are complete or not by asking questions and in between with diverting with various interruptions. But that is to test your knowledge. Basically, what examiners expects you, they wanted to assess your knowledge completely, and at the same time, most importantly, they'll see how safe you are in your approach. This is most important. And also, in between questions and interruptions, they'll see how your overall balance and level-headedness, which is very most important than having a knowledge. And also, when case is operative surgery is asked in the morning session, after case presentation, please try to apply all your knowledge to that particular case or scenario always. This is very important. Don't tell regarding general operative surgery, but fit into it should be molded towards your case. That is very vital there where you can get maximum marks, and also that is very much useful in our clinical practice also. So when it comes to anyway definition or procedure, you will go through an indication. Suppose in morning case session, if the case is asked, right, hemicolectomy for a cancer, then examiner expects you to tell in terms of cancer surgery. Usually candidate, most of the times I have seen, they'll tell removal of terminal ileum and right colon and middle of the transverse colon. That is not correct for a cancer surgery. You have to tell in terms of pedicles. You have to tell, I'll remove, if it is a right-sided lesion, I'll remove the ileocolic artery, ileocolic pedicle, right colic, and also right branch of middle colic. Along with that, whatever associated bowel. This answer examiner expects you. This is the difference between knowledge and application. Suppose if the same case is a Cox or ileocecal Cox or a Crohn's disease which is proven on a pre-operative biopsy and the patient is having ileocecal obstruction, then there is no need to tell in terms of pedicles. Then you can simply tell, I will do a limited resection of the ileocecal area. So, and also pre-operative preparation. Suppose if in the morning case scenario, pre-operative preparation, always don't jump and tell the incision and all these things. Patient preparation is most important. You are doing daily in your ward, but please apply that. You will do all nutritional assessment, cardiac assessment, risk assessment and all these things. And also, apart from regular and high risk consent, please don't forget the special consent wherever applicable, because when you are removing an organ, suppose you are doing an orchidectomy or a mastectomy or you are doing an ileostomy, it's not, you may think that you have told the patient, but it is your responsibility that the patient should understand your language, what you are meaning. Otherwise, show some other patient who is having stoma, like that. These are all things are important. So, if you tell in the same way, practical way, the exam is not a different thing. And also types of anesthesia. You should know briefly, because most of you are having postings of 15 days in anesthesia, so you know what is epidural, what is high epidural, spinal, local and all these things. But at the same time, examiner wants to assess you basic things like how do you prepare a Gylocan adrenaline mixture, how much dilution you do, and depending on the patient, how many ml you give. All these things you please calculate and prepare in advance, and that will be helpful not only for exam and also practice point of view. And also position, there's some, sir is telling a lot of this Trendelenburg position and all these things are very important. These are standard things. Please just spend 2 minutes on that and you will never forget in your lifetime. What is that 15 to 30 degrees head low, and reverse is 15 to 30 degrees head up, and all these things. And also know the names of all 7-8 Trendelenburgs. Suppose if you comes to Cockers, again same thing. Cockers incision in the neck, Cockers right subcostal incision, and also the Cockers manure, So if you do like this kind of a memory pegging, it is not only useful in exam, you can tell when examiner asks just like that. You will not be penalized if you don't tell, but if you tell, you will have the satisfaction of answering the question. And apart from that, this will have a lot of impact on future, that the kind of knowing about the great surgeons will inspire you to do something. And also the incision. When you are telling incision, just don't tell skin, and you also try to tell quickly the muscle, whatever layers, if time is there, and go accordingly. And also steps of the procedure. When you are explaining steps of procedure, it is important. Suppose examiner may ask you, you are doing a emergency splenectomy. What are your steps? You are doing an elective splenectomy. This is a common scenario. Steps are different from emergency and elective. In emergency splenectomy, you will try to mobilize the spleen laterally and bring it into the abdomen and put 3 to 4 clamps without injuring the tail of pancreas and stomach. Whereas in elective splenectomy, the important step is you will first ligate the splenic artery and then short gastric vessels, and then you go to the tail of pancreas, and then you remove the lienorenal ligament and all. These are the simple things we will be doing in our daily practice, but in exam point of view, we don't prepare for that. So, between you friends, final year exam going students, sit together and discuss this kind of exam scenarios and discuss with teachers. And these things not only helpful in the exam but also in the patient care. And when it comes to the complications, this is the most important thing. When complications are asked, you please try to tell intraoperative complications, immediate postoperative or late postoperative complications. This is very important. And also you tell how you manage. And at a postgraduate level, it is important when you on table you are telling an important complication. Then you never tell that you are not only it is your duty to tell the how you manage, and also one more C is there. That C you should not forget. That is call for help. That is very important. That indicates the safety of you as a surgeon. Even though you are capable of managing that complication, you should tell, I'll call for help, and meanwhile I'll manage. These simple things will go in a long way. Things look simple, but there you can gain more marks. Examiner will always wants to assess your safety as a surgeon. And so what surgery they'll ask? Every surgery is important. So in terms of acquiring knowledge and in terms of patient care, there is no minor or major surgery. The magnitude of surgery may be small or large, the procedure may be simple or complex. But every surgery, whether it is a minor or major, it is very important for you and for your patient. And in terms of assessment of knowledge in examination, there is no minor or major surgery for examiner. So examiner may assess you with a simple incision and drainage and will give you more marks if you tell it correctly. And even if you ask a major surgery, even if you feel that you have told nicely answer, but you may not get the major marks. So please don't think about the magnitude of surgery. You will get more marks. You may get more marks by giving a good answer for a simple incision and drainage. So surgeries may vary from a simple incision and drainage, tracheostomy, emergency procedures like appendicular surgeries, perforations and all these things, obstructions, any surgery they can ask. So it is very difficult to tell the types of surgeries they may ask. This is only a broad overview. So prepare for all the surgeries, but while you are preparing, please try to start with simple surgeries first and then go for the complex surgeries. And I wish you all the best, and thank you very much for your patient hearing. Thank you so much.
I think it was very nice, very comprehensive. One addition to, you said complications. You also said intraoperative, postoperative, early, late. But that's a good point. But one thing is, you should tell common complication first. Whenever you say complication or any operation for that matter, including circumcision or thyroidectomy and mastectomy, hemicolectomy, gastrectomy, you name it, but tell the common things first. If you say the rare things first, you will not appreciate it. Then if at all, if you have thorough subject, you can go to the rarer and rarer one by one. But please always tell the common complication always first. That's the most important thing. I don't want you to be over smart and tell the examiner. Examiner doesn't want you to be smart. So please remember that one.
For operative, only in delay. General complications, don't forget this.